So next I would like to invite Dr. Manoj Chandra Mathur sir who will be speaking on ocular hypertension, when to treat. Welcome sir.
Yeah, thank you. Thank you and good afternoon. I shall be speaking about how ocular hypertension, when to treat. So, structural functional correlation forms the cornerstone of diagnosis of glaucoma. Though IOP is not included in the definition of glaucoma, it still remains the only modifiable risk factor, if we may say so, in the treatment of glaucoma. It may have a limited value in diagnosis, but is very important in prognosis. We all know if there is a intraocular pressure over 30, we stand a risk of vascular occlusion. So, if you see this bell curve here, statistically, a mean of 16 millimeters pressure is considered normal. Shift of two standard deviations either side gives a range of 10 to 21 as the normal range for intraocular pressure. We have to also understand that the field loss may be present even when the IOP is in the normal range. On the other end of the spectrum, there may not be any field loss even in a high IOP with a patient with high IOP. So, before we want to see whether to treat ocular hypertension or not, you must know a little bit about the ocular hypertension treatment study. This is a multicentric randomized prospective clinical trial designed to study the effect of topical ocular hypertension medication in delaying the onset of glaucoma. So, what they did is they included patients with IOP in the range of 24 to 32 with a normal visual field and a normal optic disc. So that structurally and functionally the patient should be normal but with a high intraocular pressure. And they aimed for a 20% lowering, and the maintained value was around less or up to 24 millimeters of mercury. The results of this study, the mean IOP reduction was 22.5% in the treated group compared to just 4% in the control group. After 5 years, 4.4% of the treated group converted to glaucoma compared to 9% in the control group. This gave a eureka feeling that there is a 50% risk reduction. But what we need to understand that on the corollary, now over 90% of the untreated patients did not convert to glaucoma. That means if you have observed 100 patients under control, only 9 of them progressed, whereas have we unnecessarily, is it required to treat the remaining 91% is for us to decide. So, POAG conversion was more detected on disc photographs, about 50% compared to just perimetry in about 40% of the cases. So, the risk factors of progressions were thin CCT. So the value of correction of intraocular pressure with the central corneal thickness, the value with higher IOP, if there is a disc hemorrhage, you need to suspect some structural defect. Older age people, you have to suspect probably the chances of conversion are more. Larger cup disc vertical ratio and higher PSD on perimetry. These were the risk factors that were considered. Early medical treatment does reduce the cumulative incidence of POAG. However, it is not essential to treat all ocular hypertension patients. The absolute risk reduction for conversion is greatest in high-risk individuals. So who are these high-risk individuals? The conversion to POAG continues over the last 15 years follow-up with the available data. The risk factors of progression were older age, thin CCT, you must treat higher IOP, above say, theoretically they may say 28 to 30, but practically in our clinical setup, for me, the personal cutoff is about 26 to 27, cupping with a sharp edges, disc hemorrhage, larger vertical cup disc ratio, and higher PSD on perimetry. And associated risk factors, if the patient has family history, frequent change of glasses, diabetes, hypertension, thyroid disorders, post-surgery or post-trauma, and long-term use of steroids. If the intraocular pressure is high, optic disc is normal, if the perimetric changes are not there, with these risk factors, with the presence of these risk factors, you can think of treating these ocular hypertensive patients. So, if you see some cases here, the discs were like this, the intraocular pressure 26 or 25, CCT was in a normal range. And if you see the OCT, the superior nasal segment was sharp, Unlike in glaucoma, we expect changes in the superior temporal or inferior temporal segments, but here the superior nasal segments were sharp with 26-27 pressure with some associated risk factor. It is for you to decide whether you want to treat the patient or not. If the patient is easily accessible, if the patient is having a regular follow-up with you, probably you can observe, otherwise treat such patients. Now, if you see this, a 49-year-old female with family history of glaucoma, typical, the mother had distinct glaucoma with 27 millimeter pressure. I would like to personally reduce the pressure to about 20-30% and be happy with the normal visual fields. And now if you see, when you do an OCT, the RNFL fibers are all normal, but the GCC complex is significant. There is a significant loss. This study shows that when there is a GCC significant loss, a high intraocular pressure is better treated than observed. So if you see this, especially on the disc on the right side, it looks very ominous. It's a very big cup with a very thin inferior temporal segment. You are tempted to treat, but with a better follow-up, with an absolutely normal OCT, over a period of time, absolutely normal fields, I am continuing to observe this patient. So the discussion is yours. Every patient is different. Every ocular hypertension you need not treat. But there are associated risk factors, which I have enumerated earlier. In such similar situations, you need to take a clinical judgment whether you need to treat an ocular hypertension or not. Ultimately, this final case I always present whenever I am speaking about the medical management. Just see this case. All parameters okay. These are the optic discs. Visual fields are absolutely normal. When I did the OCT in the right eye, there is a superior temporal and inferior temporal thinning. I went back, and at that time, this is my learning curve with OCT. Subsequently, I came to know about the GCC. When I studied, when I looked back, then I started seeing some sort of a retinal nerve fiber layer drop out here. Then I put the patient on treatment. Subsequently, I learned about the GCC significance, and when I repeated the OCT, where is the STIT segment gone? There is nothing. Go back. Review the case again, the OCT 6 months apart, superior temporal and inferior temporal segment thinning in the first instance, absolutely normal in the second instance. If you see the decentration, where was the OCT measured? In the first instance, in the April OCT, it is totally decentered. So a peripheral segment was measured, and that contributed to the thinning of STIT. So we need to know when to treat. Is that defect, what you are seeing, is an artifact? The man behind the machine is equally important. Thank you very much.
Thank you.